So, good evening, everyone, and welcome to today's smart learning about interpreting MP-MRI of the prostate for CA prostate, not necessarily cancer prostate, but all the other few disorders which we commonly see in relation to the prostate. It's my pleasure to introduce Dr. Yuvraj. Yuvraj has been a friend for many years. He graduated from JJ Hospital, later worked in Tata Hospital, and now is the head of robotic surgery and uro-oncology at Kokilaben Dhirubhai Ambani Hospital in Mumbai. He has a vast experience of thousands of cases of radical prostate, and I think he has brought forth a very important thing that we have to learn to read MRIs, and we can't leave it to our radiology colleagues and give away this opportunity to learn MRIs. And I think it's very important, not only for students, but for consultants. With this few opening remarks, I request Dr. Uttam, Secretary USI, to please start the proceedings with
Yeah,
his opening remarks.
I think our President-elect Dr. Keshav is also there. If he wants to say something before I speak, Dr.
No, no,
Keshav.
no. Go ahead, Uttam.
Okay, thank you. And then good evening, everybody. As usual, knowledge sharing is the main purpose, or knowledge acquiring as well as sharing for this sort of program. And I must say that a urologist will be a good urologist once he knows something about the radiology also. And I personally believe, as when you operate, you understand or you read the anatomy every day, and the same anatomy you are going to read in the imaging. So the better correlation for any clinician will be when he or she himself or herself knows how to read the MRI and then applies to a day-to-day practice. So I think I don't need to waste much of time. And if today's students will have to know, not only the students, all the urologists will have to know about the MRI. And I believe whoever is attending, they have the basic knowledge of MRI about all the sequences and how to interpret. So I can see the topic is interpretation, not the acquisition. So it is all about interpretation of the MRI prostate. And as Dr. Sujata has already told, it is not only about the prostate cancer, some benign lesions and differential diagnosis. And I think Jubraja is going to tell us in next 1 hour time. And all the best. I hope it is going to help us. Thank you.
Thank
Yes,
you, Dr.
Yuvraj, you may
Uttam,
please start.
Dr. Sujata, madam. And I thank ISU and USI to give this opportunity. So in next, whatever, 45 minutes to 1 hour, I'm going to take you through the interpreting MP-MRI prostate as we discussed now. So this is one of the common investigation we order for, but uncommonly we read it. So that is the reason I felt so we should be more aware of the reading of MRI, like what we do for CT scan in other conditions like kidney cancer, bladder cancer. So unfortunately, so MRI was left behind. I think this is the high time that we have to go ahead and start studying about MRI, how to interpret. And more or less, I think we will be able to do it not as good as radiologists, but still whatever the clinical aspects is necessary, that much we can interpret. Hope that there will be some technical terms. Even I'm not a radiologist. All of you know that. So I don't know the technical details of each aquarium, the machine, and the physics and all those things. But we'll see how clinically we can use this image to diagnose prostate cancer. Yeah. So we will discuss interpretation. Typically, what is exactly a protocol of MRI, and we will go through some basic anatomy to understand abnormal pathology. So we should know anatomy, how it looks, and then we just go through some benign findings to differentiate, to know how the cancer appears. And then in that connection, we also look into pyrite scoring, and then a few cases, examples where, how we interpret this MRI. I think this is the sequence what I'm going to take you through. So we know that prostate cancer, MRI was used earlier also, now also. The only difference is that earlier it was only specified for a loco-regional staging. That means After doing biopsy, we used to order for MRI, not before, just to know whether it is spread somewhere. So now it is completely changed. So we do this investigation for the diagnosis, very important, risk stratification to guide biopsy. We always do as a pre-prostatectomy protocol and planning the radiation therapy. Focal therapy without MRI, we can't do focal therapy. Active surveillance monitoring, and even a treatment monitoring post primary treatment for the prostate. So we use MRI of the prostate in many settings, and I think this is the reason. So the application of MRI is increased. So better we understand this one. So prostate cancer, all of us know, is a good proportion of prostate cancer are clinically insignificant. Can we identify this significant, clinically significant cancer? So that is our goal. How do we know whether it is significant? There are many criteria for that. One of them is a Gleason score. But actually, there is no single definition for significant prostate cancer. And we know that Gleason 6 is highly unlikely to be a significant, and Gleason 10 is a very, very significant cancer. Somewhere in between, we get lost. So pyrite scoring in MRI and MRI scan has come as very important to define or detect clinically significant prostate cancer. That means once you diagnose prostate cancer by pyrite scoring, you can more or less say that with the 80% sensitivity and specificity, this is a significant cancer. We are not there to diagnose insignificant cancer. So generally, what do you mean by significant cancer? Gleason score more than or equal to 7. Volume of the tumor, which is more than point or equal to zero point 0.5 cc, or presence of extra prostatic extension. These are all significant factors on MRI as well as the biopsy. So can we predict Gleason score on MRI? So now that the world is changing, so now we are going for AI era, artificial intelligence era. So where we can predict Gleason score just looking at MRI. But now we will go to the basics today. So prostatic imaging reporting and data system, PIRAT score, it is a standardization, acquisition of the images, interpretation of images, and reporting of MRI. So this system has revolutionized how MRI is done for prostate cancer. So the version 1 was explained in 2012 in a simple algorithm, and it was modified in 2015, introducing dominant sequence in different zones, and then adding diffusion weighted images. And now what we use is PIRAT 2.1 version, in which is modified in 2019. And this was used because we had some confusion in sort of the on a few of the scores, so we want to avoid those shortcomings. So that is the reason PIRAT V21 2.1 was is currently in vogue. So when you say
Yuvraj, can I just interrupt you? There was a
yeah,
message that your slides are not completely seen.
yeah, so what should I do?
Now it
So
is seen,
how
madam.
to remove this?
It is
Now
seen.
it is seen.
Okay,
That
okay. Fine, good. So
okay.
now
Now it is seen. Yeah.
I
fine.
think
So
there is
when
a
I
there's
hello,
Please
hello.
there
proceed.
there is a
Proceed.
one rectangular block scene. Is it for everybody or only for me? Yeah, now it is okay.
Now it is gone.
Okay. So how do I see my camera there, my picture there?
No, your picture is seen. Slide is also seen. There was one block
Okay, fine. No
which
issue,
was
no issue.
yeah.
So
Now it
now,
is okay.
yeah. So once you say prostate MRI, so there are sequences what we use. So that is the acquisition of the images. So there are two types of sequences. One is anatomical, another is functional. You have to combine these two. Anatomical images are all T1 weighted images and T2 weighted images. And functional images are diffusion weighted, apparent diffusion coefficient, and dynamic contrast imaging. These are all functional imaging. So fortunately, even without giving contrast to the prostate, we can acquire functional status of the tissue. So that is the advantage of doing MRI in prostate. So how we use these sequences to interpret, let us see. Okay. So typical prostate MRI protocol includes a MRI which is done in 3 Tesla machine, preferably. 1.5 is also okay. It is not that bad, but 3 Tesla is preferable. So it contains 4 sets of images. One is the first predominant sequence is T2 weighted image, which is taken in an axial manner. Remember, all are important. because unfortunately, the radiologist will give you 100 of plates, which have no use for us. They have to give only 4 or 5 images. So if you see here, so this is an axial image, T2 weighted. And also we have to have a, which is only for the prostate. This should not be in the pelvis. They give a big pelvis picture. That is not called as prostate protocol. And then we have to have a same prostate in a coronal or sagittal section, one section. So these are the two important T2 weighted sequences we should get. Number two, then we have to have a diffusion weighted images. Diffusion weighted images are usually done with a high B value. So high B value is nothing but the speed of water molecule that should be very high. So it should be more than 1400. So along with diffusion weighted images, ADC map comes automatically. So these are the second most important sequences we should have. And the third one is a T1 weighted image. T1 weighted images, if you see here, so hardly you can make out any anatomy. It looks more or less a gray zone, gray areas. And T2 weighted images are very good for the understanding the anatomy of the prostate. And remember, once we take a T1 weighted images, we have to use contrast, that is dynamic contrast enhanced MRI. Remember, contrast is interpreted only after T1 images. It is not read in T2 images in any part of the body. And this is the third part. The fourth is that one large field of vision means the entire pelvis, including bifurcation of aorta down to the perineum, so that we know the entire pelvis, to know the lymph nodes and etc. etc. So these are the four sets of images the radiologists are supposed to provide you. So not hundreds of images which we cannot understand at all. So we'll go by one. What does this sequence means? So not to repeat or not to go to the details of physics, T1 images, we know that T1 weighted images are the longitudinal relaxation time, and this highlights fat and other tissues with high signals while suppresses the water signals. Whereas T2 weighted images is nothing but transverse relaxation time, which highlights water. So T2 weighted images are very good for fluid and for the tumors. Remember, T2 weighted images are good for fluid, understanding the fluid and the tumors. Fluid always looks white in T2 images. So that's how we have to remember. So anything which is white in the MRI film, so you have to automatically think that this is T2 weighted images. So because of the water molecule, the movement that the color will come. So that's what I'm saying here now. If you go to the diffusion weighted images, it is the movement of water molecule which is important in the tissues. If the water moves, it loses signal and appears less white. If it is more white, if it moves, it loses the signal. If it is stagnant, it glows up. So that is the reason in the tumor doesn't in the tumor water doesn't move properly. And so then you'll get different images. You'll get a very high density images like this, white and diffusion weighted images. Why? Because it is a tumor, water speed is less. If the water speed is more, then it becomes hypo. If water stays, it signals white. That means water stays in tumor. Normal tissue, it is faster, water molecule speed. If water moves less, it partially retains the signal. Water in tumor versus normal tissue is the one which differentiates tumors. That's all. Remember that water movement in the tumor is less than and water movement in the normal prostate. This difference differentiates tumor from the benign conditions. So apparent diffusion coefficient is exactly opposite of diffusion, DWO images. And, it will help us because there are situations where you get the, high DWO signal with a low ADC map is a tumor. Sometimes it will be opposite. This is also high. That means it is not a tumor. It has to be opposite. One is high, one is low. If there is any discrepancy, it doesn't fit into the criteria. The last one is contrast imaging. So we give gadolinium, and once we give gadolinium, we just look at whether there is a contrast enhancement or not. So you can see the red line, if the contrast enhancement is there, and rapidly it goes down. That means it is a tumor. Type 3 is a tumor. Red line is a tumor. Type 1 is not a tumor. Type 2 is borderline. So that's how DCE is interpreted as. So if you go to the MRI basic points, normal prostate has homogeneous low signal on T1 weighted images. If you see here, the T1, there is no differentiation at all. And more often, T1 is used in prostate only to detect hemorrhage inside the prostate, which looks white on T1 images. I will show you the images later on. Only for hemorrhage we see. And then zonal anatomy is best appreciated in T2 weighted images, comprise of low signal central zone. Central zone is very, I'll show you a little later on, and high signal peripheral zone. This is a high signal peripheral zone. T2 weighted images, high signal peripheral zone, mustache type. You can see this. Transitional and the central zone looks similar and loosely termed central gland. And most of the homogeneously hyper, 75% of the cancers happens in this peripheral zone. That means there is something happens in the peripheral zone. And again, these are all divided into different sectors. We'll come to a little later. There are many sectors. And transitional zone, this is the transitional zone where 25% of cancer happens. And how to detect, we will see later on. And this is the anterior fibromuscular stroma. So when I say anterior fibromuscular stroma, there are no glands there. If there are no glands, no water. If there is no water, it is dark. That's all. And anatomical capsule, surgical capsule. So we have two capsules which we have to differentiate and also look at the neurovascular bundle, bladder, everything. So one by one, if you see here in this picture, T2 weighted image, this is the axial film and this is the coronal film. Two over. And then we have, this is the DW weighted images and this is the ADC map. And then we have T1 weighted images and then we have one more contrast. Here, this is the contrast image. And then one large field of vision. So we have totally seven pictures. That's all. 7 pictures predicts entire prostate. Although you have to move it. This is if you take it as a video, you have to move it front and forth. Then only we can appreciate. Yeah. So if you let us just show the video so we can appreciate. See now, if you see here, this is the base of the prostate, seminal vesicle, and coming down. So you can see this is the mid gland. So this is the transitional zone, and this is the peripheral zone, and this is the apical region. So from cranial to caudal, base, mid, and apex, you have to identify in this area. And then if you go to the anatomy of the peripheral zone and the transitional zone, you can make out. So this is the transitional zone. You can make out that it is a very heterogeneous appearing and it is not homogeneous like a peripheral zone. You can see peripheral zone on either side. And again, I told you these are all T2 weighted images. The peripheral zone looks bright. And then this is the anterior fibromuscular stroma. So this is how we identify in different level. Again, base, mid, and apex of the prostate. And this is the anterior fibromuscular stroma. You can see here. So compressed, there are no glands there, only fibrous tissue. So that is the reason it looks black. So this is the normal anatomy which I'm explaining. And then the central zone. If you see a central zone is little confusing. This is at the base of the seminal vesicle where it enters the prostate. It looks, if you see here, it looks, hypo intense, confuses with tumor. So there are certain criteria which I'll discuss later on, not to confuse central zone with a tumor there. So if you see here, this is the central zone. These are the two seminal vesicles joining here, entering into the this is something called as lenticular type. So this is not a oval or something like elongated. So that is the reason. So we can easily identify it. In cross section, it looks like a tumor. So that is the reason you should have a section which is coronal. So again, after looking into these different zones, then we look at the neurovascular bundle at 5 and 7 o'clock outside the peripheral zone here somewhere, and then we have a surgical capsule. So this is the surgical capsule, compressed transitional zone in junction between the transitional zone and peripheral zone. This is the surgical capsule. Anatomical capsule is somewhere outside the peripheral zone. And then we look into the bladder, any abnormalities like cystitis and also seminal vesicle on either side. Easily you can appreciate, especially in the large seminal vesicle, convoluted tubules. This is the normal anatomy of the prostate. So if you see here, you can go through the entire pelvis. This is the aorta, bifurcation of the aorta. And then this is the aorta, you can see here. And then, come down, trace those. These are the common iliacs. You trace the arteries, you can go down. So this is the vein which is coming down, and these are the external iliac artery vein, and all the nodes will be somewhere here. So this is the obturator fossa. So this is the internal iliac vessels. So this is how you just move it and identify any lymph nodes in this area. And in addition to that, we also look into the mesorectal nodes. Next to the rectum, you have to identify any nodes are there on either side. So this is how we identify the lymph nodes after tracing the vessels. So that's about the basic anatomy of the prostate gland. So then let us go to the sector map. Little confusing. Actually, this is very good because if somebody says, so there is a tumor in the peripheral zone on the left side in the posteromedial aspect, in the mid of the gland, mid of the prostate gland. So without blinking my eye, I should understand where exactly is there and what is the size, everything I should understand it. So for the better understanding and reproducibility and to explain to the others, so this sector map has been created. If you see here, if you see this sector map, there are totally 41 sectors, 38 for the prostate, 2 for summer vesicles, and 1 for external sphincter. So the prostate is divided into base, mid, and apex. So we'll concentrate only on the peripheral zone. If you see the peripheral zone here, peripheral zone on either side is divided into anterior zone, posterolateral, and posteromedial. Three sectors, right? Three sectors. So 3 into 3. 3 means base, mid, and apex. So finally, it will be around 3 into 3, 9 sectors only on one side. So on either side, it becomes 18. So that's how it is divided, peripheral zone, where majority cancer happens, so peripheral zone. And similarly, transitional zone is divided into only anterior and posterior. Anterior, again, at the base, mid, and apical level. And then we have anterior fibromuscular stroma, right and left. Right and left, and either from base, mid, and apex. And then we have right and left central zone and some nervous cycle. So these are the sector maps. These are all very important. Actually, when the MRI is interpreted, they are supposed picture in on this sector map so that it is very easy during surgery. So that is the reason we should do it before surgery when we read the MRI scan. So before going how the cancer prostate looks, so we have to understand how a benign condition of the prostate looks. The most common benign condition of the prostate is BPH. How does it look? If you see it, it's always from the transitional zone, but it can extrude into the peripheral zone. And in the BPH, the transitional zone looks like an organized chaos. Means if somebody sees without knowing that everything looks like a tumor for us. I used to feel the same thing. So now the stroma, whatever the transitional zone, the BPH can be a stromal, glandular, or both. Stromal, glandular, or both. So many times, if you see here, the nodules are circumcised round. Round. Remember, the round is different, oval is different. Circumcised nodules and or we have band-like areas. If you have a circumcised nodule like this is glandular. And band-like this are all stromal. Sometimes even the nodule can be stromal, but the entire texture is heterogeneous. So variable T2 signal. So T2 signal is variable. If it is a bright one, it looks like glandular. If you see all these bright areas are all glandular areas or cystic atrophy, or you have to have a stromal nodule like this, then it becomes darker, T2 dark. That means the T2 intensity or the light exactly doesn't tell that whether tumor is there or not there, but this is how a normal BPH looks. It can look hyper, hypo, depend, but most of the nodules are all oval, round. And usually the DW signal and DCE signals are not useful in transitional zone. So mainly it is T2 image or T2 weighted images are very commonly used for transitional zone. And so for the peripheral zone, we use DWI. So that will come little later. So how does the hemorrhage looks? I told you in the beginning, T1 weighted images are only to detect hemorrhage, whether diffuse or focal. You can see here, these are the hemorrhages post biopsy. So earlier, you remember, we always used to tell that don't do MRI. Now also we tell that don't do MRI within 4 weeks after biopsy because of this problem. If there is a tumor in between, if there is a large hemorrhage, we cannot identify the tumor. So that is the reason. And many times the blood comes out of the prostatic capsule like this, and then we think that the cancer is spreading. It's very difficult to interpret. That is the reason we are not supposed to do MRI. If it is not done before biopsy, don't do it at least minimum 4 weeks from the date of biopsy. Okay. So next comes the prostatitis. Remember, the most common benign condition of the prostate which mimics cancer is prostatitis. Always there is a confusion, difficult to interpret because prostatitis can be a diffuse, focal, or combined. Some areas diffuse, some areas focal. It's very difficult to identify. So it is very common. We know that prostate is very common in patients above 50 years of age. And how do we identify? So usually in the peripheral zone, it decreases the image. So T2 weighted images decrease, that is hypointense, and ADC signal in peripheral zone. Okay, but can be positive, even it can be contrast enhancing also, although it is false positive. But what is the key factor which differentiate is that the morphology is band-like. You can see here they are all band-like, wedge shaped or diffused like this. You can see from here, the left transition, I mean, peripheral zone still here. So the cancer won't happen like this. So cancer will be round or oval and markedly restricting means so you will get a round hypointense on DWI. So that is how we identify tumors in the peripheral zone. So if it is a linear band-like or a diffuse one, so then we don't call it as a tumor, it is inflammation. Remember, even we can make out many other times, sometimes there is a gray area which is difficult. So other findings like cyst, prostatic cyst, as I told you, this is a T2 weighted image. Cyst contains fluid. It looks white. Calcification, all calcification in MRI looks hypointense. Unlike in CT scan, it looks very bright like a fluid in MRI. In MRI, all stones look hypointense. It's very difficult to make out. So we'll go to the cancer now. After understanding how benign conditions, we'll go to the cancer. So now, how does the cancer in the peripheral zone look like? So it has got a very high restricted diffusion. That means the water is not moving, it is showing darker or hypointense. Remember, the primary sequence for the peripheral zone is DWI, not transitional zone. Transitional zone just depicts the anatomy, that's all. We don't identify cancers solely on T2 weighted images. That's the commonest error what we do. It is the DW bright and ADC dark. So that's how we identify. So now, if you see here, this is the T2 weighted images. In T2, we see hypointense region, and in DW, we see the same region, which is bright because water molecules are not moving, and ADC is exactly opposite. In the same area, I should get hypointense on ADC. So in the same area, and in the same area corresponds to T, just to know that T2 weighted images we have done. So primary images are DW and ADC. So it is not that simple. This is a very simple, you can make out an oval shaped lesion in the right posterolateral. Mostly this looks like a mid gland. So this is the sector map, but it is not simple. That is the reason we have developed PIRAD scoring. It's PIRAD stand for Prostate Imaging Reporting and Data System, and it more or less, as I told you, it correlates with clinically significant prostate cancer. How does it significant? PIRAD 1 to 5 scoring is there. 1 is very low chances of very low likelihood of having cancer, less than 1%. 5 is very highly likelihood of having cancer, clinically significant cancer, which is up to almost 90%. So 1 and 2 we consider as benign. 4 and 5 malignant. Again, so we have equivocal or indeterminate PIRAD 3. So how this PIRAD scoring is done and based on what? Let us study. So this is the only picture we are supposed to remember. So first I'll concentrate only on peripheral zone. Don't see the transitional zone, that will come to later. Peripheral zone, as I told you, primary sequence is DW imaging. That means in DW we score into 1, 2, 3, 4, 5. That is equal to PIRAD 1, 2, 3, 4, 5. Scoring in DW 1, 2, 3, 5 is equal to PIRAD 1, 2, 3, 5. That was the earlier V1 version. So afterward, they completely changed. In V 2.1, what they did was that because 3 was indeterminate, we were unable to make out whether 3 should be biopsied or not biopsied. They gave contrast, dynamic contrast. If the contrast is negative, it remains as 3, but DWO3, if the contrast is positive, becomes 4. Simple. So we use only 2 sequence in peripheral zone, DW and DCA. Other things are like, T2 and others, they just help you to, make out the anatomy. That's all. So now let us see how this DW scoring 1, 2, 3, 4, 5 is done. If you understand this, peripheral zone scoring becomes very easy. So if you see, as I told you, it is more than 1400 high B value we have to have, that automatically emission takes place. So now the DW score 1 means, so there is no abnormality on DW imaging. So if you see here, this is the T2. This is just to know the anatomy where it is. And if you see here, it is the same. And here also it is same. That means this is 1. There are no abnormal areas in the peripheral zone. And then we have linear or wedge shape. You can see here, there is a hypo area, but this is not round. It is linear. That means it is 2. So you can say, sir, ye kya hai, ye kya hai. So these are all, the water molecule movements, differentiation, difficult to make out. This is consistent. If you see here, this is bright here. You can see this is bright here. This is light here. And same area is hypo here. But only thing is this is linear. So that is the reason we have to keep it as 2. And this comes only by repeatedly looking at them and reading and discussing with the radiologist. And then 3, so we have low ADC or DW signal, but not both. Remember, one is markedly high, one is markedly low. No. So you can see can be markedly hypo or markedly hyper, but not both. So they are not, it cannot be equal. So it has to be different. And in focal number 4, it is nothing but DW imaging very markedly hyper, ADC markedly hypo. In same area, if you can see here, this is not linear. This is almost round, very small. Small means this may be 0.5 cc. So you can see lesion here, and lesion here. So if it is less than 1.5 centimeter, it becomes 4. And the same lesion, so you can see here lesion, almost left peripheral zone is involved, hyper, and then ADC hypo and T2 hypo. When you see these 3, if it is more than 1.5 centimeter, it becomes 5. So DW score 4 and 5 is just related to the size, not on anything. So sometimes what we say, oh, it's 5, at 5, so then it may be a very high grade lesion. No, it is not like that. It just says that the size of the lesion is more. If the size is more, it corresponds to the high lesion score, that we don't know. But so this is how we interpret. So takeaway message is look for focally markedly low ADC signal, high DW signal. That's all. If you look into these two, so the white T2 images helps here. Suddenly, if you look here, it looks confusing. So now you look at the peripheral zone on T2, you have some area doubtful, then correspond it with DWI and correspond with the ADC. Suddenly, if you look here, you can't make out anything. So that is the reason TW image will help us to locate the lesion, approximate lesion, which is confirmed basically from DW. I hope that we have understood something about DW scoring. There is a predominant scoring for the peripheral zone. So what is B value? No need to go into the detail of that. And as I told you earlier, suppose if it is a 3, that means markedly hypo on ADC, that is cancer actually, markedly hyper on DW, that is also cancer, but not both. If it is both are there, it automatically goes to 4, right? So here, if you can see, little bit of, this thing, and there is no marked hypo. It is almost looks equal. So that is the reason this is kept as 3. Then how do I differentiate whether it's a cancer or not? As we discussed earlier. So we have to give contrast. Once we give contrast, if it is positive, becomes 4, negative becomes 3. So in DCA, it is only positive, negative. There is no number. So if you remember this graph, DCE is only positive or negative. That means scoring is nothing but DW scoring. They are kept it as per rad score. That's all. So if you again come back the same in a nutshell, same picture 1, 2, 3, 5 DW scoring. 1, 2, 3, 5 this W scoring is nothing but pirate scoring and with dynamic contrast enhanced positive or negative. So that's with this algorithm, we can identify tumors of the peripheral zone. So now let us go to the transitional zone. Transitional zone tumors are difficult to identify, especially in the beginning. So let us see, we know that transitional zone predominant sequence is T2 weighted images. So T2 weighted images, how does the cancer looks? So normally, as I told you earlier, BPH, because BPH is very common here, we have nodular, normal array, round, completely encapsulated nodule like this, normal or typical nodule. This is number one. Again, when we number 1, 2, 3, 4 in T2 weighted image is nothing but 1, 2, 3, 4 pyrite score. So one is nodule with a complete encapsulation. Two is atypical nodule, partially encapsulated, but homogeneously circumscribed without capsule. Even that becomes 2. So 1 and 2 are benign nodules. Sometimes we get some picture like this. There are two nodules and in between it is hypo intense in between two, and so these are all stroma. So this is not cancer. Suddenly when there is hypo intense, then we think that okay, this can be cancer. No, between two nodules, if there is a fill up the blank, so then that doesn't indicate any malignancy. So number three, so don't read about number three now. We'll go to number four so that number three will be understood better. So number four is, if you see here, you can see here lenticular non-circumcised. Remember, in peripheral zone, it has to be a circumcised lesion, whereas in transitional zone, it is a non-circumcised but a lenticular, homogeneous, moderately hypointense. So now, if you see this picture, the lesion is very large, so it becomes 5. That's all. So 4 and 5 are same. If you see here, 1, 2, there is nothing. There is a nodule here, well encapsulated nodule. One is, the entire, there is no lesion at all. It is seen. And so 2, you can see this is the stromal nodule, not a glandular nodule. And then 3, we didn't discuss that. So this is the lesion. 4, little smaller one, less than 1.5 centimeter, more than 1.5 centimeter. So if you see here in this area and this area, as I told you, this is an organized chaos in the in the transitional zone. When it becomes cancer, this looks like an erased charcoal appearance or a the what do you call that, thumb stamp, whatever you call. So fingerprint appearance. That means you just put a fingerprint on the, so that the remaining thing is erased. So our erased charcoal appearance. So to take away message, the tumors look homogeneously, moderately hypointense, non-circumcised or lenticular in shape. There may be in any area of the transitional zone. So this is how we identify based on the TW scoring. So number 3, again, borderline. We get a heterogeneous signal intensity with obscured margins, but generally they don't meet any criteria 2, 4, 5. Even I didn't understand much about 3, how to identify. But if you see this nodule, you can see that there is a nodule here, little bit irregularity here, but still it doesn't feel, it is not a lenticular one, it is round one, little bigger one, so we can put it either 2 or 3. So that's the reason we don't go in detail. So I didn't try to identify 4 and 5 lesions. So again, if you come back, so what we do is that, so that is the primary sequence is T2 weighted images, and secondary is that we use diffusion weight. So diffusion weighted images is useful for both. So again, it is only for, so you can see here, diffusion weighted images. We already had the score earlier, markedly low ADC, markedly high DW, size criteria. That's all we use. Only 4 or 5. That means if it is a 3, 1, 1 to 4, it becomes 3. 5 becomes 4. So this is, you need not, this is very difficult to remember, but only remember 3 1, because 3 is the one, it is a borderline. So if you have a 3 lesion on T2, suddenly you go to the DW in the same area, if it shows as 5, more than 1.5 centimeter, markedly high DW and markedly low on ADC, then keep it as 4. So little confusing, if you keep on thinking and if you keep on visualizing these images, it's quite easy to remember. So this is how transitional lesions are, zone lesions are detected. So apart from this pyrite scoring and lesions in different zones, we also use MRI for staging. So we, whether it's confined to the gland or if it's coming out of the gland, you can see here, or we use the lymph node detection, and sometimes even bony pelvis we can identify bony lesion. That everybody knows it how to do that. So typical reporting of MRI, how we want to report. We know that there are 7 images they are supposed to give us, representative images. In addition, if they don't give CD, in addition to that, when the report says it should be in this order only. So they have to write which machine they have used, what sequences have they have taken, then they have to measure the size of the gland, any abnormal anatomy for they have to identify, and then identify the lesion and describe in terms of sector, number, size, characteristics based on MRI sequence. And then they should give pyrite scoring. Now also one of the premier institute in Mumbai, just couple of days, there was no pyrite scoring. So then I had to write it on the paper, call them up, and then they give the pyrite scoring. Very unfortunate, but whenever anybody does PMRI, they have to mention pyrite scoring. And then look into extra prostatic extension, seminal vesicle, any local spread, lymph nodes, bony lesions, and then, as I told you, 7 images they should provide. So this is a simple MRI reporting they are supposed to give. Many times, if you read the report, it is so theoretical, we are unable to follow anything. So now let us go to the clinical cases. So this is the normal prostate. Okay. Normal prostate, how it looks. So as I told you, T2 weighted images, T1 weighted images, we just see it, any hemorrhage. There is nothing here. You can see that from, you just scroll between up and down just to see anything, say anything significant there. And then we move on to the next images. Yeah. So now we'll go to the, we have to measure the volume also. That's what we discussed. And if you see here, so now, this is the coronal view. This is the axial view. Okay, then comes the T2 weighted images. You can see here, T2 weighted images. So you can easily identify the, peripheral zone, differentiate the anatomy. So this is the, repeatedly I'm showing because this is how we learn. Seminal vesicle here, base of the bladder. So this is, so a little bit of median lobe there. And this is how it looks, T2 weighted images. Keep on scrolling and identify. So this is the median lobe, what they are showing here. So this is how it looks in T2 weighted images from top to bottom, base, mid, and apex. Now, if you can see here, there was something that looks like inflammation. This is the transitional zone. Okay, so this is the coronal one. Again, come and, especially useful for central zone. Then we have DW. You can see here, so the entire prostate, there is nothing in the peripheral zone which we can make out corresponding to this one. So once that is done, we know that, so, this is this image, and then we go for ADC map. ADC map, as I told you, so this is very bright. And suppose if there is a hypo, this should be brighter in the same area. So that's how we do it. Hypo in this area and hyper in this. Okay. Yeah, you can see here. So this looks like inflammation here. And then we go to, see here, this is the central zone. So the same thing which we are seeing here. See, now this is the central zone. So don't confuse. That's the reason suddenly immediately go to the axial, coronal section, then you'll be able to make out. Then dynamic contrast imaging. So you give the contrast and see the entire prostate is taking up the dye. There are no areas where there is an enhanced uptake of the dye. So we don't expect anything because there were no lesions here. So this is how it looks. So then seminal vesicles, bladder. So this is the normal sequence we have to think. This again, I told you this one. So this is nothing but the entire wild field of vision. So everything you have to look into the in the field. So now we'll go to a clinical case. This is a 62-year-old, 68-year-old male, PSA 6.4 and DRE, hardish area. There is not a very convincing nodule in the right lobe. So now I'll just actually, whenever I take in person, I'll ask questions. Somebody has to interpret, whoever has listened properly, but here it's not possible. If you see here, this is the prostate. So we are running. This is which one? This is a T2 weighted images. So I am identifying the anatomy here very clearly. So now we can make out. So once coming from base to apex, you can see here in the peripheral zone, somewhere here, there is a hypo intense area. That means I am not going to say it is a cancer. Just I am identifying some abnormality in the peripheral zone on T2 because T2 is not a image for identifying lesions in the. So now if you see here in the benign, there are no lenticular or erased charcoal appearance lesions here. So we did not because the T2 is very good for transitional zone. And then I did the DWI. You can see the same area, there is a uptake. So same thing which we can see here, seen here. So there is an uptake, abnormal uptake. That means bright area, not uptake, bright area on DW imaging. So that means so there is something. I have to reconfirm it by looking into ADC. So you can see ADC, there is hypo on the same area. So that means there is a lesion around 0.5 centimeter, right posterolateral mid gland lesion measuring about 0.5 centimeter, hyper on DW or severe water restriction on DW, and ADC it is hypointense, and the capsules are intact. So now this patient, so also because we had a doubt, we gave the contrast. Contrast may not be useful that much, but we had a very small lesions. So we want to reconfirm it. And then we gave the contrast. And you can see there is a contrast enhancement also. That means everything put together. So it is saying that there is a small lesion in the prostate. We did a fusion biopsy. Transperineally, it came as 3+4=7. And the patient underwent, I think this patient underwent, I don't remember, mostly HIFU therapy because it's a 3+4 with a small lesion in the periphery. So it's a good candidate for focal therapy. So this is one example. The last example, 70-year-old man. These are all real case scenarios. PSA 15, rectal examination normal. So whenever there is a high PSA, rectal examination normal, two things I always keep in mind. One is prostatitis, another is transitional zone or anterior fibromuscular tone because we cannot reach there. So that is the reason. So now if you see this image again, so this looks to be T2 weighted images. T2 weighted image is very good for transitional zone. On this image, we can identify, you can see here, somewhere here. Yeah, I just stop that image there. Sorry. See, now this is the lesion where if you see this is chaos is there, but here in this area, all chaos is removed, erased. So that means there is something here. So now, because if we have any doubt about this, then what we have to do, the secondary sequence is DWI. So in transitional zone, the next sequence should be DW imaging. So we gave the DW images. You can see here, it is very bright here, very bright here. You can see this bright DW corresponds to the lesion which we have seen in the transitional zone on T2 weighted images. That confirms. So there is a malignancy there. So ADC again is showing same area hypo. You can see in the very nicely seen hypo area in the same area. So it has to correspond to the same area, mid gland, mid gland, mid gland, mid gland. Otherwise it gets confused. And then, so we did the fusion biopsy. Actually, it's a very high grade cancer, 4+4=8. Patient underwent radical prostatectomy. So I think with this, we can conclude it. But the learning comes once you understand the basics. So if you don't go back and then keep on revising at least one scan per day for next 1 month. So again, after 1 month, you will tell. So again, you explain because you will forget it. That is the reason you have to just keep on looking into the films. Whatever you understand, you just see that film, and then you can easily identify that. Hope I have made it a little bit overall view. There are many examples I had, but for the interest of time, I just gave only 2 clinical scenarios and 1 normal prostate. Thank you so much.
Hello.
Thank you very much,
Yes, sir.
Dr.
Yeah, we can hear.
Can I ask a question, Yuvraj?
Yes, sir.
See, can you do away with, if it's not PIRADS 3, can you do away with dynamic contrast enhancement?
Yeah, if
We are certain
means
it
what?
is 1 or 2 and certain it is 4 or 5, because we are
Uh-huh.
going to distinguish between 3 and 4 only with DCE. So
Mhm.
can you do away with this DCE if it is 4 or
No,
5 and 1 or 2?
correct. So now, if you add DCE, that is called as a multi-parametric MRI. And if you don't have it, there is something called as biparametric, which is coming up, especially in the patient with renal failures. We cannot give dye. So in that situation, if it is a 3 on basic imaging, so we need not give DCE, especially for peripheral zones, there is no need. For transitional zone, it is required. Even there, if we can accept it, it's fine. If it is a larger lesion, anyway, we can biopsy it. See, the idea of doing MRI before is just to know whether biopsy is required or not required. That's all. That is the main thing. So in addition to that, we may get many other criteria. So we can get away with without doing DCE, especially for peripheral zone lesions, because we don't need it.
Yeah.
Trouble is always in the transitional zone. The peripheral zone, most of the time you are able to pick up, but the trouble is always in the transitional zone is
Yeah,
because it's quite heterogeneous.
correct.
Unless
So in
some-
that, I think better to use contrast wherever it is possible, feasible.
So, Dr. Yuvraj, very nice presentation. I want just
Yeah.
comment. Normally, postgraduates will have confusion. How does it look on DWI? How does it look on
No,
EDC?
your voice is not clear.
No. Postgraduates, they have a confusion. How the cancer looks on DWI, how it looks on ADC. So what I tell them is the blind rule. Remember W for white in DWI. It is D for dark. So DWI looks white, ADC D for dark. So easy
Yeah.
to remember.
Yeah. So these are all mnemonics which we
Yeah.
generally try to remember.
I have a question.
Once you keep on watching it, then
Correct,
you
correct,
identify.
correct.
Okay.
So if somebody doesn't have access to 3 Tesla and somebody is doing 1.5 Tesla, so will it be same or is there any difference in the?
Yeah, the resolution is not as good as a 3 Tesla machine, but still we can, if there is nothing there, even it is good. It's not like that, we may miss little smaller lesions. That is fine, because smaller lesions, generally we say that smaller the lesion, the score is less. And that's what we believe. So, but I think that is fine. Even if you have 1.5 Tesla, only thing is that radiologist should know to report prostate MRI. Problem is that so many centers, they get good volume, and many centers, so they don't have that amount of cases, that number of cases. So in that situation, once in a while, if they report it, it is like us only. Once in a while we operate, we know what are the results.
Correct.
But PIRADS, actually, you have to report in a 3 Tesla only, or can you report in 1.5?
One also is okay, no issue.
Yeah.
We prefer 3 Tesla. That's what the discussion is.
Yeah, nice.
Any other question?
Any more
Uttam?
comments or questions?
Not the questions, but the comments only.
Yeah.
Like I say that the best time to learn is during the residency period. And I tell my residents, you should develop some friendship with your radiology colleague. And you spend half an hour or 1 hour a week or so, you can learn. It is just like a ECG. You don't have to be a cardiologist to diagnose something, at least the basic stuff, because anyway, you are going to put the knife. So you should have some basic idea. So you are not going to be a good radiologist or a perfect radiologist, but you should know what I think this is the purpose for this session, and you have served the purpose very rightly, very successfully, and I'm happy for that. And I'm sure maybe in future we can incorporate one radiologist also and see how do they interpret. This is the clinicians interpretations every day for day-to-day practice, and how do they like the Surya Prakash was telling, so D for D and this thing. What I say, since radiology is, if you can give a lay person what he's seeing, either a black or a white or a gray, nothing else. So you know the anatomy and you interpret based on these colors. And that's it. And that is the last statement. I think it was really helpful, and it is going to be helpful in future also, the recordings.
Thank you.
Thank you, Yuvraj.
Thank you.
Surya,
Thank you, ma'am.
Yes, madam.
Surya,
Thank
will
you.
you conclude? Yeah.
This session is recorded, number of the students are
Yes,
asking.
yes,
You
yeah,
can watch later on also in our from the USI
Yeah.
website, all the ISU recordings. So thank you very much, Dr.
Thank
Yuvraj.
you. Thank you. Good
Thank you.
night.
Thank you so much.
Good night. Good night. Good night.
I
Bye.
must tell you, this is the maximum attendance. You've got 160 people attending your session. Is really
Thank you.
good. That itself shows that the talk was excellent. Thank you so
Thank you.
much.
Thank you so
Thanks,
much.
thanks, and
Thank
good
you all.
night.
Okay.
Good night.
Thank you,
Okay.
Dr.
Okay. Good night.
Okay.